Hello, ladies and gentlemen, and welcome to another video at the Pharmacist Academy. Woo! How to monitor patients on aminoglycosides. Now, as a pharmacist, one of your main jobs is to make sure whenever a patient is on medications that require drug level monitoring, you want to make sure that it's done correctly, and you want to make sure that based on the levels, you're able to adjust accordingly. Now, aminoglycosides are one of these agents that require that. So in this video, I'm going to show you exactly how to do this. Now, to begin, I just wanted to give you a brief introduction. So when we think of aminoglycosides, we know the mechanism to be, a medication that binds to the 30S ribosome subunit. And this is what leads to the bacterial protein synthesis inhibition. But then again, we also know that aminoglycosides have a bactericidal activity, so that means it's able to kill the bacteria. Now, this is actually done through the cationic molecules of the aminoglycosides that create holes in the outer cell membrane of the bacteria. And this is what leads to the bactericidal activity. It's concentration dependent, so as the dose increases, the rate and extent of bacteria killing increases, right? So the higher the dose, the better the effect, the better the efficacy of the medication. The post-antibiotic effect, which is the continuous suppression of bacterial growth after exposing the bacteria to the antibiotic. So after the patient receives an infusion of aminoglycosides, they're able to still suppress the bacteria from growing from anywhere between 2 to 6 hours. It's poorly absorbed from the GI tract, and that's the reason why it's administered in many different routes, but there's no oral formulation. It's primarily distributed within the extracellular fluid, so anything or any disease or situation that may shift the amount of fluids in your body or change the amount, whether increase or decrease, will definitely affect the distribution of this medication. It's well concentrated in the bone, synovial fluid, and peritoneal fluid. It has poor distribution into the respiratory secretions, CSF, and adipose tissue. It's renally cleared. So the half-life is usually 2 to 3 hours, but if you have any kind of renal function impairment, the half-life will increase. In terms of bacterial coverage, we usually use these agents to cover aerobic gram-negative bacilli, such as E. coli, Klebsiella, and the more important one, Pseudomonas. They also have a synergistic effect, so when we use agents like gentamicin in conjunction with beta-lactams, we're able to actually target gram-positive cocci infections like streptococcus and enterococcus. Clinically, we use these agents for UTIs, sepsis, skin and soft tissue infections, pneumonia, mycobacterial infections, specifically with amikacin. In terms of adverse effects, the one that we are more common with is that these agents cause nephrotoxicity, and this is usually reversible with dose reduction or discontinuation. And this is why it's so crucial that we monitor the drug levels and adjust appropriately. It may cause ototoxicity, and this can be irreversible. So usually if we feel like a patient is going to be on these agents for a good amount of time, we want to make sure we get an audiometry test. It may occur after the end of treatment, so this could be something that we can monitor for even after the patient is off the treatment. And it may also cause neuromuscular blockade. Now, there's two main ways we dose aminoglycosides. One being the extended interval dosing. So this is also known as once daily aminoglycosides or high dose aminoglycoside. And this is because we give high doses based on the patient's weight, and this is given over an extended period of time. So it's not that you infuse it for a long period of time, it's just that you give it less often. So usually at least 24 hours in between. But this could range from anywhere from 24 hours to, 48 hours, let's just say. Now, initially, we had the traditional dosing, which I will talk about after this. So, we actually started off with traditional dosing in clinical practice, but then we started using the extended interval dosing. And this is mainly because of these reasons here. So, one, the bacterial cytoactivity is actually concentration dependent. So the higher the dose, the more efficacious this medication is when it comes to killing the bacteria. The post antibiotic effect that I spoke about also is also influenced by the peak concentration, right? So the amount of medication that the patient gets the first time, which allows it to hit the bloodstream and increase this peak concentration. Now, this was really the selling point, and this is why we really started using these agents. It has similar efficacy to the traditional dosing, but less nephrotoxicity. Okay, so with that, I mean, it changed clinical practice. That a lot of patients started receiving this extended interval dosing scheme for aminoglycosides. Now, after the first exposure, right, gram-negative bacilli may actually become refractory to the bactericidal effect with subsequent doses. The drug-free period provided by extended interval dosing helps aminoglycosides preserve this antibacterial activity. So if a medication is being, or the aminoglycoside is being dosed every 8 hours versus, let's say, every 48 hours, so studies have actually shown that when the bacteria is being exposed to the medication, several times throughout the day, so 3 times in this case, if you're doing every 8 hours, this actually may lead to refractory, right? So the bacteria may become refractory to the bactericidal effect with subsequent doses. And this is something we definitely do not want. Now, although the extended interval dosing is like the greatest thing ever, right? It seems there are certain patients who actually cannot, receive aminoglycosides using extended interval dosing. So patients with renal insufficiency, pregnancy patients, because we can't really determine the fluid status, right? The amount of fluid in their body. You cannot use this dosing scheme for synergy for gram-positive infections because when we do this, we usually use lower doses of the aminoglycosides. Patients with ascites or edema, burns, hemodialysis, and cystic fibrosis. Now, if you have a patient, let's say you want to start on the extended interval dosing, right? And you want to use agents like gentamicin or tobramycin, the dose is usually 5 to 7 milligrams per kilogram. But like I mentioned, in this scenario, these medications actually work better when you give higher doses, right? So usually in clinical practice, even though the range is 5 to 7, we usually go with 7 milligrams per kilogram. And as you will see later on, when you're monitoring these patients using the Hartford Nomogram, you must use 7 milligrams per kilogram. It's only applicable for patients who receive doses of 7 milligrams per kilogram. For amikacin, the dose is 15 milligrams per kilogram. So the dosing is based on the ideal body weight, unless the actual body weight is lower. Then you want to use the actual. Now, if the patient is obese, you want to use the adjusted body weight. Now, when you're monitoring these patients, you want to use the Hartford Nomogram. And as I mentioned earlier, this will only be applicable for doses of 7 milligrams per kilogram, simply because this is how it was studied. Now, you want to draw the level 8 to 12 hours from the start of the infusion of the first dose. Okay, and you want to plot this level on the Hartford Nomogram to determine the appropriate frequency and to see if it needs to be adjusted. Now, for gentamicin or tobramycin, you just draw the level 8 to 12 hours from the start. Then you plot it on the nomogram. For patients receiving amikacin, since it's 15 milligrams per kilogram, you want to divide that by 2 and then plot that on the nomogram. Now, if the level falls on the line, you want to choose the longer interval for administration. And let me show you exactly what I mean here. So this is an example of the Hartford Nomogram. And as you can see, we have the y-axis, which is the concentration, right? So the amount of medication that was in the blood 8 to 12 hours after the start of the infusion. And on the x-axis, we have the time between the start of the infusion and the sample draw, right? So I said it's 8 to 12 hours. So if let's say you drew the level at 12 hours and you got 8, right? So you got to connect it. So you bring it up here and it's probably going to fall somewhere in here, right? So in that case, you want to make sure the patient is getting the dose every 48 hours. Now, let's just say that when you did it, it fell on the line exactly. Then you always want to choose the longer interval for the patient. If it falls right here, you want to move to the traditional dosing simply because you're basically saying, okay, 8 to 12 hours after we started this medication, you still have this amount in your blood, right? Which is a little bit too high. So what we're going to do is actually give you lower doses more frequently so that you're able to clear it. Now, for the follow-up monitoring, you want to draw the trough 30 to 60 minutes prior to the dose in patients demonstrating any acute changes in the renal function. And if the patient is not experiencing any acute renal changes and their renal function is stable, you can actually draw random levels at least once weekly. And the target troughs are less than 1 for gentamicin and tobramycin and less than 4 for amikacin. Now, if the duration of therapy is anticipated to be more than 2 weeks, usually we want to consider, doing an audiometry test for these patients because of the risk of ototoxicity. Next, we have the traditional dosing. And as I mentioned earlier, this is really how it started off with reduced doses and more frequent administration of the aminoglycosides. Now, it's used when extended dosing interval is not appropriate. So I gave you a list of patients who are actually excluded from using the extended interval dosing. And this is the dosing here for your information. As you can see with the traditional dosing, we usually range from every 8 hours in patients with good renal function to, doing every 24 hours or actually dosing these patients based on the level. And I will explain exactly what I mean as we go on. For monitoring patients, you want to draw peak levels in these patients 30 minutes after completing the third dose infusion. And why do we draw peak levels on these patients compared to the extended interval dosing? Because the extended interval dosing, we expect the peak to be high, right? That's the reason why we are doing it. We want high peaks, but the patient is getting it less frequently, right? So that's okay. For traditional dosing, you don't want high peaks, plus the patient is getting it more frequently, right? That could lead to renal toxicity. So in this case, you want to draw a peak level 30 minutes after completing the third dose infusion. So if the infusion started at 9 a.m. and it's for 30 minutes, let's say, they usually infuse, let's say 30 to 60 minutes. So in this case, 9 a.m. to 9:30 a.m. Then 30 minutes after the completion, so 10 a.m., you're going to draw the peak level. You draw the trough level 30 to 60 minutes before the fourth dose. And this is because that's when the medication is in steady state, as we are all familiar with. For hemodialysis patients, you want to draw peak levels 30 minutes after completing the second dose, trough levels immediately before dialysis. And these are the target levels here for your information. So I have this picture here to kind of show you what I mean by peak and trough. And the picture is a little blurry, but I hope you could see a little bit of what I'm seeing here. So let's say the first dose is right here, right? So we have the y-axis, x-axis. Y-axis is the concentration of the aminoglycoside in the blood. And the x-axis is just telling you the time, right? So the doses. So you give the first dose here and the levels go up, right? right away, right? Because it's an IV administration. So in this case, this would be the peak levels here. And then the levels start to drop because your kidneys are starting to clear it, or let's say it's being distributed into the tissues, but it's not in the blood, which is good, right? Then if you give another dose, the level goes back up. Okay? So when it comes down here, this is the trough. So this is the lowest level of the medication in your blood before you gave the next dose. Now into the clinical practice scenarios or questions. Now before we get into that, I want you to remember just one thing. Dosing aminoglycosides is an art. And what I mean by that is that you could have the perfect patient on the perfect dose, being infused at the perfect time in the perfect hospital, but if you check the levels, it may still not really correlate with what you expected, right? The levels may still be high for some reason, or it may be low when you actually thought that that was the perfect dose for the patient. So just keep that in mind. That in clinical practice, every patient responds differently, and no matter what the patient's weight is or renal function is, sometimes the unexpected can occur. Now, principles of aminoglycoside dosing and monitoring. So I just wanted to go over these things before we start the practice problems. Safety comes first, then efficacy. Usually, when we monitor patients' peak levels and patients who are getting aminoglycosides, the peak levels are really for the efficacy of the medication, right? And the trough is for the safety, right? How well is the body, clearing it or distributing it? Okay. When it comes down to it, always consider safety first. All right. So if you get a patient who has high peak and a high trough, you want to make sure you fix the trough first. Okay. Trough is the most important thing that you always want to fix first. Then you can fix the peak. Next, break the rules if safety is a concern. Okay, so normally we say, okay, wait till patient gets 3 doses, then check the trough before the fourth dose, right? Or check the peak at this certain point. But if the patient is experiencing renal function, I don't care. Check the levels. You don't need to wait till the third dose, right? There's no point of waiting. All right, the patient may start accumulating. So check the levels if you need to, skip doses if you need to. It's okay. All right, that's why you're able to check the levels to make sure the patient is getting therapeutic amounts of the medication. Now, we have this concept known as dosing by levels, and this is for patients with impaired renal function, so either acute or chronic. Obtain trough levels, and depending on result, consider holding dose or giving it. Okay, so with this one, we give the dose as we go. So, depending on the patient's levels and renal function, we may hold the dose, we may give the dose. Okay, it's not common to dose by levels based on the peak. Why? Because the trough level tells us how well the kidneys are clearing the drug. If the peak is high, it doesn't necessarily mean that the kidneys are not clearing it or the medication is not being distributed. It just means that the dose is high, right? The dose is high. It doesn't really tell us much, okay? Now, you always want to make sure you correct the trough before the peak if both of them are out of range, as I mentioned. Now, for these practice problems, I want you to assume that all patient information listed are correct. Okay, so the serum creatinine, the creatinine clearance, trough, peak, etc. So the creatinine clearance, I actually calculated all of these based on the patient's, weight, age, serum creatinine. So they are correct, but if it's wrong, please just assume it's correct. So patient number 1, Mr. Johnny Law. Question number 1. What would be the initial dose and frequency for this patient if started on gentamicin using traditional dosing? Now, the patient's ideal body weight is less than the actual body weight in this case. So therefore, you must calculate the dose using the ideal body weight. Now, I'm using the 2.5 milligrams per kilogram in this case for the gentamicin. So normally it ranges from 1 to 2.5 milligrams per kilogram for traditional dosing. But in clinical practice, we tend to use the higher end of the range simply because, as I mentioned before, the aminoglycosides have a better effect with higher doses. So you multiply that by the ideal body weight and you get 153.52 milligrams, which must be rounded to the nearest 10 milligrams for gentamicin and tobramycin and to 50 milligrams for amikacin, simply because of the way the vial is supplied. Now, the patient's creatinine clearance is over 60, so the initial dose and frequency will be 150 milligrams IV every 8 hours, infused over 60 minutes. Question 2. Assuming all doses were administered exactly at the same time that it was due, if the infusion was started on July 1st at 9 a.m., at what date and time will the peak and trough be obtained? Now, the peak level is taken 30 minutes after completion of the third infusion, and the trough is 30 to 60 minutes before the fourth dose. And I have the doses listed here for you, with each one being separated by 8 hours. So we have the first 4 doses. Now, based on the timing, both levels should be taken on July 2nd, the peak level at 2:30 a.m., because the third dose on July 2nd started at 1 a.m., but it's being infused for 60 minutes. So the infusion ended at 2 a.m., and the peak is taken 30 minutes after completion of the infusion. So in this case, 2:30 a.m. The trough is 30 to 60 minutes before the fourth dose. So the fourth dose is due on July 2nd at 9 a.m. So the trough can be taken anywhere between 8 a.m. to 8:30 a.m. before that fourth dose. Patient number 2, Mr. Jesse Yates. On July 3rd, the team would like to start the patient on amikacin for pneumonia. What would be the initial dose and frequency for this patient using the extended interval dosing? Based on the patient's ideal body weight, it's less than the actual body weight, so therefore you must calculate the dose using 65.9 kilograms. Now, for the extended interval dosing of the amikacin, it's 15 milligrams per kilogram, so we multiply this by the ideal body weight, we get 988.5 milligram, and we round that to 1 gram IV. Now notice I don't include any frequency here, and that's because for the extended interval dosing, I will be checking the levels 8 to 12 hours after I start this infusion to determine the correct frequency that the patient should be on. And let's just say this was being infused for 1 hour, right? If the infusion began at 9 a.m., at what time should the levels be drawn? Okay, so as I mentioned before, the levels for the extended interval dosing is usually 8 to 12 hours after the start of the infusion. So in this case, it will be at 9 p.m. Assume the levels came back as 15.6 micrograms per ml and is plotted on the nomogram. What would be the new frequency? So if we take a look at the nomogram, we have the y-axis, which is the concentration of the medication, right? So the level that you drew. And on the x-axis, we have the time between the start of infusion and the sample drawn. In this case, the concentration was 7.8, so it's right here. And the level was taken 12 hours after the start of the infusion, which will be somewhere here. So the appropriate frequency should be every 48 hours. So amikacin must be divided by 2, as I mentioned earlier. So you plot it, you should get 1 gram IV every 48 hours. We have patient number 3, Mr. Henry Rose. He's receiving tobramycin 220 milligrams IV every 8 hours, infused over 30 minutes. They have the patient's renal function here for you, and the peak and trough, which was drawn on July 3rd, and the administration time and date here. So the peak was taken at 3 p.m. on July 3rd, and the trough at 9 to 9:30 p.m. on July 3rd. Now the question is asking us to assess the patient's tobramycin dose, the trough, the peak, and the renal function. And the time currently is 11 p.m. on July 3rd. Now the dose and the time of the peak and trough is appropriate. okay? As we could see, the peak was taken at 3 p.m. So 30 minutes after completion of the third dose. The third dose was given on July 3rd at 2 p.m. It was infused for 30 minutes, so it ended at 2:30 p.m. So 30 minutes after that, 3 p.m. is when we took the peak. The trough was taken on July 3rd at, let's say, between 9 to 9:30 p.m. The fourth dose is due on July 3rd at 10 p.m. So that's like 30 minutes to 1 hour before that fourth dose. Now let's assess the patient's renal function, the peak and the trough. Now the peak level is normal, but what we see here is the trough is elevated, and also the patient is, experiencing some kind of acute kidney injury. As we can see, the serum creatinine has doubled over the past like 3 days, right? Now, serum creatinine is increasing, so the patient has poor renal function. So before you give the next dose, you must check that the levels are appropriate. Okay, so for the 7th 4 dose, right, the July 4th dose at 6 a.m., make sure the levels, the trough levels, right, is in range. So you want to obtain a random trough before you even think about giving that 6 a.m. July 4th dose. If the trough levels are normal or high, you want to skip that dose until that renal function improves. It doesn't matter that the level is normal, right? The patient is experiencing some kind of renal, impairment. You don't want to give another dose, and let's say the renal function gets worse. Now the patient is stuck with all this medication in your body. So you want to skip that dose until the renal function improves. Only consider giving a dose if the patient's renal function improves, it's stable, and the trough is in range. Question 2. Assume the peak and trough was 11 and 2.1 respectively. What would be your recommendation? So once again, the serum creatinine is increasing, so I would recommend to hold that next dose. Okay, and in this case, the peak is high and the trough is high. And as I mentioned earlier, whenever you get a scenario like this, you want to correct the trough first. So if trough levels are normal, once you get the random level, you want to skip that dose, or even if it's high, you still want to skip that dose, right? You only consider giving a dose if the patient's renal function, in this case, improves, it's stable, and the trough is also in range. And when you're given the dose at that time, the dose could be a little lower since the peak was high. So you could lower the dose to 200 milligrams, about 200 milligrams. Assume the peak and trough was 3 and 2.2 respectively. What will be your recommendation? Okay, so very similar scenario, but in this case, the peak is low. So once you consider giving the patient the dose, right, when the renal function improved, it's stable and the trough is in range, the dose could be a little higher since the peak was low last time, right? So you can increase it to 250 milligram if needed, but there's no right answer because we don't know, right? 250 milligram might be it. It might be 260 milligram that might do it. 240 milligrams, right? We're not really sure which dose will either push the patient over or not. Patient number 4, Miss Ellen Brown. She's receiving gentamicin 160 milligrams IV every 24 hours infused over 60 minutes. Now, whenever you see that the medication is being given over 24 hours, do not automatically assume that it's probably extended interval dosing, right? It can also be traditional dosing, but the patient does not have good renal functioning. So the question is asking us to assess the patient's gentamicin dose, the trough, the peak, and the renal function, and the time currently is 6 a.m. on July 4th. The dose is appropriate, but the renal function is worsening, okay? So assuming that the renal function was stable, we would have followed our regular recommendation, which will be to take a peak on July 4th at 11:30 a.m. and the trough on July 5th, anywhere between 9 a.m. to 9:30 a.m. before that 10 a.m. morning dose. The random trough level is needed first to determine if the July 4th dose can be given, right? Simply because the patient's renal function is not that great. Okay, so it doesn't even matter if this is the patient's baseline, right? So let's just say that on July 1st, the patient came in with baseline levels of 2.2, right? So in that case, then we could say the patient's renal function is not that great, but it hasn't changed, right? So still, if the renal function is not great, you still want to make sure that you check the levels before you give the dose. Now, if the trough levels are normal or high, you want to skip the dose until the renal function improves. Okay, unless the patient's baseline, the serum creatinine is already high, then you want to consider giving the patient that dose, right? Even though the renal function is not that great, but that's just your baseline, right? Only consider giving a dose if the patient's renal function improves, stable, and the trough is in range. Patient number 5, Ms. Jalen Cruz, receiving tobramycin 130 milligrams IV every 8 hours, infused over 30 minutes. As we can see here, the peak was taken at 6:30 a.m. on July 2nd and the trough at 11 to 11:30 a.m. on July 2nd. Assess the patient's tobramycin dose, the trough, the peak, and the renal function. The current time is 11 p.m. on July 2nd. The dose and the time of the trough draw is appropriate, but the time of the peak is not appropriate, right? So once again, the peak is taken 30 minutes after completion of the third dose. So in this case, the patient received the third dose on July 2nd at 4 a.m. They received it for 30 minutes, so it actually ended at 4:30 a.m. So the ideal time to take it was supposed to be 5 a.m., but they took it at 6:30 a.m. Okay, so that was wrong. The trough is correct in this case. Now, when we assess the peak and the trough, we notice that the peak is low, right? The trough is normal, but the peak is low. Now, the peak was a little lower because it was taken late. Possibly, right? If it was taken, let's say at 5, maybe the levels would have been normal at 5, right? It would have moved, it would have increased to 5, right? Because that's the cutoff. It would have been at 5 instead of 4. Now, give the July 3rd dose, that 4 a.m. dose, and obtain a peak 30 minutes after completion of that infusion. If this peak comes back low, increase the dose. If it comes back high, you want to give a lower dose next time. Assume the peak and trough level was 8 and 0.1 respectively. Assess patient's tobramycin dose, trough, peak, renal function. The peak is normal. Okay, so you want to continue the same dose, right? The trough is technically normal in some cases, because like you may say less than 2. Sometimes they say between 1 to 2. It's technically normal. You could consider giving a dose if you need to, if you feel like the patient is not really improving clinically, but if the patient is improving clinically and the peak is at a good concentration, but the trough is low, you could just continue to monitor the patient. Assume the peak and trough level was 9 and 1.7 respectively. Assess the patient's tobramycin dose, trough, peak, and renal function. The peak is normal, continue the same dose. The trough is normal, so keep the same frequency. And that would be the end of this video. As you can see, dosing patients on aminoglycosides, as I mentioned, is an art. Okay, so sometimes you get the perfect dose for the right patient, but the levels still does not reflect. And also keep in mind, whenever a patient is experiencing renal impairment, do not be afraid to obtain levels before the patient gets that dose. And also keep in mind that when it comes to monitoring these patients, everybody may have like different recommendations, right? Some people are more conservative and others are not. Okay, but as a pharmacist, you always want to be conservative. That's why you're able to monitor these patients' drug levels. So don't be afraid to. If this video was helpful, make sure to like, comment, subscribe, and share this video with anybody that you know who's struggling with aminoglycoside monitoring. I also have a video on vancomycin monitoring, so I'm gonna include that in the description. So make sure to check it out. Also, don't forget to connect with us on these social media networks. And until then, I'll see you guys later. Take care.